group. He as a member of the TTJ Consulting Group, he also has a normal job that is extensive. He directs the Center on Behavioral Health Epidemiology, Implementation, Evaluation Research, which is comprised of 4 research programs and approximately 60 research scientists and analysis. He's really been involved with conducting community-based research and evaluation to focus on and address the impact of substance use, violence, and inequities on youth and their communities. He's really dedicated his whole career. And since I've known him as a colleague and as a friend, Dr. Graham has applied at a community level some of his best work in identifying the most effective prevention interventions for real world settings. He's involved with 5 national cross-site evaluations for SAMHSA and CSAP funded prevention strategies. He is really engaged and has worked with over providing evaluation related training and technical assistance to 70 grantees and 600 communities through webinars, manuals, and etc. He serves as the principal investigator for National Institute of Drug Abuse funded HEAL Prevention Coordinating Center, which is a huge responsibility where he oversees and supports 10 research projects. He has an awesome methodological focus, which includes really looking at mixed methods approaches that really look at implementation and science and data. And around, he really emphasizes the importance of community context, culture, and diversity. Uh, what I like is that about Dr. Graham is that he's also a founding board member of the National Prevention Science Coalition. And this group really advocates for prevention science and the development of prevention interventions to address negative outcomes. I would encourage you, if you have not Googled this extraordinary, awesome person, I think you should have an opportunity. We're fortunate enough to have him come and address our residents and you all here in Wisconsin. We're excited to bring him to you. And it leaves, I want to introduce for all of you or present to some of you as well, Dr. Phil Graham. Dr. Graham?
I will send that check in the mail for that very, very kind introduction, Tracy. Good afternoon, everyone. I am excited to have the opportunity to present and a little daunted once I saw the breadth of folks who were attending. I often tell folks I am not a trainer and I didn't stay at a Holiday Inn last night. So you're going to get a researcher pretending to be a trainer, but hopefully in a way that's going to be useful. This presentation is really going to take a broad swath of really talking about multiple issues related to social determinants. And I changed the title a little bit to be more specific to behavioral health. And I did that for a couple of reasons. That while many of these things impact both physical and behavioral health, my work and my expertise and my knowledge is more geared to behavioral health. And I think it's important to make sure I'm speaking with what I know as opposed to what I think I know. And so that doesn't mean that there won't be overlap and intersection of the two, but that will be the major focus. Again, there is an incredible diversity of individuals attending today. And so for me, folks who've heard me present, I know I always talk about the importance of context, and context matters. That also starts with knowing who's in the audience to make sure that you're presenting in a way that folks are going to say that was a good use of my 90 minutes as opposed to I could have gotten some other important work done. So I do want to spend a few minutes. Any good researcher worth his or her salt always has to ask a few questions. And so those questions are really intended to get a sense of who's in the audience. And so we have 4 poll questions that'll only take a few minutes, and it'll help me just have a general sense of who's in the room and also where your work lies. So here's the first one. So what substance is most impacting the health and well-being of the community that you serve? So I think someone's going to put up the poll now, and we'll give you about 20 seconds to answer that question. didn't bring my Jeopardy music, so otherwise I'd count down. So about 5 more seconds, and then we'll end the poll and see what folks are saying. Okay, let's end the poll. All right, so just looking at the results, slightly more than about 38%, 30 and 36% folks focus on alcohol and opioids. Not much in the stimulant and meth space. A little on marijuana and also poly drug use. So that's important. Okay, thank you very much. Second question. Is what setting does your organization primarily serve? So that urban, suburban, rural, or tribal? Okay, in the poll. So again, a nice distribution. More than about 42, slightly over 40% are rural, followed by urban, and some, and then we have a few tribal members, representatives as well. So again, I know that thinking about the Wisconsin landscape, this makes good sense. I may have some questions about suburban and really understanding the context in which you think about doing the work. Okay, next question is, you talked about what was most impacting your community based on how your funding operates. What substance is your organization's primary focus as we think about these substances? So we'll spend about 30, 40 seconds on that. In the poll. So this was multiple choice, so you had lots of options. And so again, still most of your efforts are around alcohol and opioids, and a decent amount on marijuana, and as well as some work in stimulants and meth. Great. And last but not least, just trying to get a sense of who's in the room. So the last poll question is, what sector do you most represent in your current position? Wow, stop polling. Almost an equal number of folks in terms of prevention and treatment, about 35 exactly in each category. So my presentation is, again, my trainings in prevention. However, there will clearly be relevant applications to a treatment environment. And I'll be most attentive to that, particularly as we talk about the importance of collaboration and partnerships. So I think we'll take advantage of who we have in the room and kind of build from that. So great. So thank you. There's a mysterious person working the poll. So thank you very much. So we can take those down. So again, it's important for me to kind of know who's in the room and really think about how we deliver that. Now, also, as you know, the folks who
There's something wrong.
Phil, you've muted yourself, sir. There you go.
Now, if my wife could do that, she would be super pleased. So I'm not sure how I accidentally did that. I apologize. As you have worked with and know the folks who really put these trainings together, they're quite ambitious. And so here's what we're going to try to achieve in 90 minutes. And as I said before, this is going to be high level, and hopefully there will be opportunities to engage you at a later time. But first, we want to define social determinants of health, but through a behavioral health lens. And so that's how I'll talk about the terms today. Then hopefully explain how inequities in neighborhood conditions, education, income, and wealth, and even social political climate to some degree affect health outcomes and health disparities. And then how do you understand how differential access to wealth building policies and structures beyond just income create unequal conditions for good health in communities across the United States. And then we'll do some work identifying examples of effective local, regional, and national strategies for improving systems and policies that affect social determinants of health. And I'm going to use an example of some work I've been doing with folks in Milwaukee to hopefully put some local context to it. And then evaluate and apply the Wisconsin Governor's Order 59 related to diversity, equity, and inclusion for their prevention work. And so I hope to be able to touch on that a little bit as well. So those are our objectives that we will hopefully achieve over the next 90 minutes. About halfway through today's presentation, we'll take a small 5-minute break. I know if you're like me, we're all zoomed out, and Zoom fatigue is real. And so it's not a long break, but a 5-minute break just to refresh, and then we'll finish out the day. So with that being said, the other important thing here is to put into perspective of how I think about this work. And so what I want to spend some time today is really talking about what I call, and what others have called, upstream thinking and leadership. And this is not my term, but it comes from a recent book I've read that really focuses on the importance of upstream thinking. And that book is by Dan Heath. Now, mind you, I am a diehard UNC basketball fan, and Dan went to Duke. And so I'm trying not to hold that against him, because this is a brilliant book. And so it's really about the quest to solve problems before they happen. And so we have treatment folks on today. And so where our energies are typically focused on is treating a problem, where we will spend an enormous amount of money and not question it at all. But when we talk about preventing a problem, we have to provide justifications that are sometimes unrealistic. And the challenge for those of us who do prevention is really doing something where nothing happens, right? And so it's much easier to have tangible things like a treatment outcome. But when we talk about how do we prove that something didn't happen because of something we did, that's a challenge. This work really focused on really codifying in a very simple, straightforward way the importance of looking upstream. This concept, the term upstream, is analogous in many respects to social determinants of health. That really is, as we focus on them, that is really focusing upstream. So what does that mean? There are 3 barriers to upstream thinking. The first is problem blindness. And we're often like, I don't have time to think about what led to the problem. I just need to fix the problem. The second is a lack of ownership. Well, that is not exactly what I've been funded to do, and therefore it must be someone else's problem. And the last is tunneling, where you are so focused on a single issue, you don't look at the broader context. And so that is often based on how we fund the work we do. And so because of that siloedness in terms of funding streams, it really forces us to not think about the whole picture, but to think about an aspect of it. And so as a part, hopefully by the end of today's webinar, you'll begin to understand the importance of thinking broad about our problems, the importance of owning all aspects that lead to the problem, and really thinking about strategies that are beyond the one that you've been charged with. And so if we can begin to erode those barriers and really get us to thinking about what upstream thinking looks like. So that's a backdrop of a lot we'll talk about. And then time permitting, at the end of today's conversation webinar, we'll begin to talk about how we might answer these questions. And so there's 7 questions for upstream leaders. The first is, how will you unite the right people? And that's about getting work done. How will you change the system? Where can you find a point of leverage? How will you get early warning of the problem? How will you know you're succeeding? And then how will you avoid doing harm? And then probably most important, because of the environment in the world we work in, who will pay for what does not happen? So again, that's this whole notion of upstream thinking, solving problems before they happen. That's the backdrop of kind of how we're going to think about this work. So we're in Wisconsin. And so one of the things I wanted to make sure was that I understood as much as possible what does substance use look like in Wisconsin. And so folks from your department, Raina and others, really helped me in providing information around that. So, for example, although the world is consumed by the opioid epidemic, and rightfully so, it does not mean we don't continue to focus on the other substances. And in Wisconsin, as many of you know, alcohol still reigns supreme in terms of how it impacts the state. And you'll see by this graphic, both in terms of alcohol use in the past month, binge drinking, and also perceived risk of harm from binge drinking, you are above the state average in each one of those. So in terms of alcohol use in the past month, 64%, almost 65% said yes, compared to 55% of the U.S. population. Binge drinking, 21% versus 16%. And then perceived risk is you want to actually have more folks having perceived risk of binge drinking. You'll see that's a lower risk in Milwaukee compared to the state. So again, alcohol still is a major problem, and its annual estimated cost for binge drinking, for example, $3.9 billion. Other related alcohol indicators also in terms of alcohol include things like 24,651 drivers under the influence as of 2018 data, 1,800 juvenile liquor law violations, over 6,000 alcohol-related motor vehicle crashes, and also almost 600 per 100 rate of disorderly conduct arrests. So again, not only alcohol in terms of what it does to individuals, but how it impacts community at large is still an ongoing problem within the state. In terms of the most common services for use, you'll see again, much in 2020, the top 5 common substances in terms of services included alcohol first, almost 12,000 kind of units of service, marijuana, then opioids, cocaine, and methamphetamines. As I started earlier in saying that opioids still is the thing that's getting most of the attention, overdose drug deaths in general can continue to increase. And you'll see in this graphic, whether it's all drugs combined, multi-drug use, opioids, heroin, cocaine, and meth, all of them are increasing over time. And so as we think about substance use and behavioral health, we may focus on a singular substance, but understanding what the root causes are critically important to really figuring out how we reduce overdoses. And so to the degree and extent there's shared risk factors, shared social determinants, and we'll talk about that as it relates to the different substances, we can have profound impacts across the board as we think about how we reduce overdose deaths in time. This next chart looks at rates of deaths, drug deaths by county, and this is over a 6-year period. For all opioids is about 14.8 per 100,000. As you see where you are, the work you do is located. The darker the shades, the higher the rate. Heroin is about 5.5 deaths per 100,000. Cocaine 3.9 and meth 2.0. So again, as you're looking at this particular chart, again, based on where you live in the state, anything that's darker is higher rates of that. And then here is an example of talking about what's driving the opioid epidemic now. This used to be prescribing was a main emphasis of our focus, but you'll see there have been significant increases in where fentanyl is really the driver for most of our opioid overdose deaths. Doesn't mean prescribing and heroin don't contribute, but in comparison. And so it's important as we think about strategies if we're focusing on, prescription pain relievers and not fentanyl, we miss the mark in terms of reducing our overall death rates. And then just two more quick slides. This shows the differences by gender, and again, across all opioids, as well as prescription opioids, fentanyl, and heroin. Males are much more likely to overdose, and so you see what that distribution looks like. And here is another chart looking at data from 2020, which has the overdose death rates per 100,000. Again, darker areas have higher rates, lighter areas have fewer opioid deaths. So I'll go here. And then because we're talking about behavioral health, which includes substance use and mental health, I want to show this slide because this looks at the toxicology of suicide deaths from 2014 to 2017. You'll see again, 34% of those suicides completions included alcohol. You see antidepressants, benzodiazepine, opioids here is 19%. So again, alcohol is a major contributor in relationships to suicides in Wisconsin. So I wanted to provide some general data. Clearly, many, if not all of you, have a general sense of what those rates are, but it's critically important not to assume what your data looks like with respect to outcomes. Because if you do, you often miss changes in trends and can be focusing your resources in the wrong place. So our first major objective is really defining social determinants of health. And so I want to spend a few minutes doing that. That definition really focuses on the conditions in which we are born, live, learn, and play, and age, and how they exercise a powerful influence on the health of individuals, and I would say families and communities. And so many of the things that we come in contact with really fall in these categories. I like diagrams. So, and so these are the same thing. And so both of them really talk about the major social determinant categories that our folks are most familiar with, or the ones that are most often used. And that includes economic stability, social and community context, neighborhood and built environment, healthcare, and education. And so the vast majority of my presentation today will do a deeper dive on those three to the left, and I'll talk about that more in a minute, around economic stability, social and community context, and neighborhood environment. But healthcare and education are equally important, and so I will try to do a decent job of integrating where they show up, particularly from a systems perspective, again, as we really focus on issues of partnership development and collaboration going forward. So the first determinant I want to talk about is healthcare. And there are three major aspects of that, and that's access, utilization, and equity. Access really focuses on the ability to receive services, but that in and of itself is not sufficient. And so one of the other related issues is utilization. So you could build a set of services that are intended to address some specific outcomes, but if folks aren't using them, then you still don't improve outcomes. And so as we think about social determinants in this space, it is understanding what are the access issues, but also what drives the utilization issues. And so it's not to say that we just have these things in place, but understanding why people are using them or not. Often this is associated with equity. And so as we begin to use the term more freely, understanding what those issues of equity are as they relate to both access and utilization of healthcare services. And so that's there are other pieces that go along, but these are three I want to focus on, particularly in terms of how it relates to behavioral health work. So the next social determinant is education. And again, there's a theme here, which is three. One is quality of education, and we know there are differentials in that for a host of reasons. And so as we think about problem solving or discuss to solve problems before they happen, understanding not only what the quality is, but the quality isn't what's causing it? What's driving it? The issue around attainment is the ability to not only have access to quality health care, but the ability to be able to fully utilize it. And so that's often with respect to how folks enter in a system and exit a system. And that gets at the issue of readiness. And readiness is, for me, on two ends of the spectrum. Readiness first is understanding what it takes for young people to enter school and able to thrive. But equally important is a readiness for them to exit an education system. And so we often focus on one or the other. Very rarely do we focus on both. And so as we think about things like early childhood education, that's about readiness. And so when young people within communities show up to school, are they ready to learn? And there are a host of reasons that impact their readiness to learn. And while I said earlier, we will spend more time talking about the three on the left, not as much on education, I would be remiss if I didn't use a simple example of food insecurity as an example, that it can impact school readiness as in terms of how folks show up for school. So again, we won't talk about all the education issues and social determinants, but you'll see other places as if we impact those factors, they also are interrelated, in some respects, codependent on some of these other social determinants. So next is economic stability. And so it includes some of the things that we often perceive to be intractable. Poverty being one of those, right? And so we often say this issue around these three barriers that, I can't do anything about poverty. So it is not my problem, not my skill set, and therefore I'm focused elsewhere. At least understanding the role and importance of poverty and how it impacts people's day-to-day living is critically important. I just mentioned food security, and in the respect of impacting outcomes is food insecurity in terms of how folks show up in, for learning is a key economic indicator here with respect to social determinants. The next is homelessness, and so the ability to have shelter is critically important. That gets at both physical issues, but also mental health issues. And so again, as we think about this through a behavioral health lens, the role of homelessness in terms of how it's impacted by economic stability, but also then its relationship to outcomes. And the last is employment, which sometimes gets confused with poverty. As I often tell folks, we've heard that X number by the child tax credit, almost 50% of children are raised out of poverty. The thing I want folks to recognize, though, poverty is $25,100 for a family of four. So even moving that up to $30,000 from an empirical numbers perspective would be true. X number of kids would no longer be in poverty. But all the impacts and effects of poverty will not change with a $5,000 increase in and of itself. And so it is important to understand the context. And so this is where numbers don't lie, but numbers can be misleading. And so as we think about employment, it's not just having a job, it's having a job that has livable wages. And so, and when it's not, how does that impact how families, again, are able to live, play, and learn in the context in which they find themselves living? The next two social determinants I want to talk about are the spaces where I know the most. And so, unfair or not, that's where I'll probably spend a lot of my time talking. And the first is around social and community context. Many of you who are particularly on the boots understand the importance of understanding community context. And so here are a couple of key social determinants that really impact the health and well-being of communities. The first is violence, and that can show up in many forms, and that everything from suicide, domestic violence, sexual violence, and even verbal abuse as an example. The other piece is ACEs, which stands for, in this context, adverse childhood experiences. I'll broaden and expand that in a little to include some additional concepts that I hope will be useful as you move forward. Discrimination, and so it's the hidden social determinant that that one can't put his or her hands around. And so, what is the impact of discrimination And I'll use the context back to the healthcare system, right? So when folks have been discriminated against or had really bad experiences, even though a service may exist, they may not access it. And so understanding issues of stigma and discrimination with respect to access of these services in this context is also critically important. And then there are norms. And so how norms get set in communities and how they exacerbate it, how they expand, particularly those norms around antisocial behavior and how that impacts people's daily living, and also criminal justice. And criminal justice from a systems perspective. So understanding how laws, the enactment of laws, the equal application of laws, the application of the criminal justice system, how that directly impacts communities, particularly in terms of their stability, is another social determinant that needs to be considered as we think about what a whole or holistic community, a thriving community might look like. And the last social determinant is neighborhood of built environment. And this is where we look at things in housing. I don't know what things look like in Wisconsin, but here in Durham, North Carolina, for example, housing has gotten completely out of control. People are selling houses $50,000, $100,000, $200,000 over asking. And there's a ripple effect of that, right? You think about gentrification in communities where folks can no longer afford. And so where they had a house that now property value is going up, they have to relocate. Housing quality in ways that we often don't think about, like lead poisoning, asbestos, and the substandard housing in general, its impact on physical health, as well as then the subsequent behavioral health that follows. So again, that when we talk about neighborhood and built environment, that's an example of housing quality. Work and public safety is another. Where you work can impact your daily living. And so working in unsafe environments, working and whether that's in factories with poor working habits, being overworked and underpaid, and how that translates into how folks show up at home is another piece that we don't often think about. But folks, if you're employed, thinking about what are the work conditions that the individuals we're trying to assist, what do they look like, and how that impacts how they show up at home. And the last is community violence. And I had violence in general that happens to an individual as we think about neighborhood context. Community violence is what happens around individuals. And so the importance of understanding how just witnessing violence, for example, how that impacts mental health and well-being. So those are examples and definitions of how we think about the general terms of social determinants of health. I want to pause for a few minutes to see if there are questions in the chat or whether or not there are comments, pushback, feedback, clarification on any of those definitions. So Tracy, Tasha, if there are any questions in the chat related to these definitions or comments, if you share those, and if anyone wants to come off or mute and ask them now, the mic is open.
Yes, there are no direct questions. However, we have a few comments from Rebecca Nicholson. I apologize. She just responded that your comment about the housing, she's having that same issue in Door County. Houses flying for way over market value, and many are being flipped to short term rentals, which is exacerbating the lack of affordable housing issues they already have. And so that was from Miss Rebecca. And that is all I am seeing right now in the chat.
So I will continue, and thanks for monitoring. So here's one of the things I want us to think about. And so this article gets at it, and I know it says opioids, but it could just say American substance use crisis. And the need for an integrated public health approach. And so I want to really overemphasize that, and you'll see one of the critical themes in this article, in which you guys will all receive the slides, and you can take a look at the full article if you like. These four underlying pieces. One, develop a deeper understanding of social contextual circumstances of substance use and misuse at both the individual and population level. And so taking these definitions I provided for social determinants and really understanding them both at the individual and population level. The second one, and really the primary focus of these sets of presentations today, is really understanding the role of social context in relationship to engagement in prevention and treatment services, and the role of social supports. I'm going to harp really hard on the importance of social connections and the power of social connections in the work we do. The other is taking a developmental perspective and attending to the role of family, peers, and social identities. And the last one is exploring the role of technology as a setting for social interactions and interventions. Because of COVID and in this era of social isolation and social distancing, technology has become even more important, I think, in all of our work. And so embracing and understanding the role of technology in the delivery of services, even as it relates to social determinants, becomes an important piece. But because I'm a prevention guy, my orientation and my presentation and learning and training is really around the role, importance, and increase understanding of how prevention can be a partner to those in the treatment space, those in the recovery space, and those in the physical health space. And so I'm really understanding what that might look like in practice is really what I want to almost over promote as we think about how to best go about doing this work. So that's part one in terms of really defining social determinants. Now I want to spend a little time in this second question or objectives around explaining how inequities and neighborhood conditions like education, income, and wealth, and social political climate affect health outcomes and health disparities. And so, and again, this is going to really be top of the trees, but really intended to really make the point about why this conversation around social determinants is so important in the current times. Social determinants really operate at every stage as it relates to addiction. And so whether we're talking about drug initiation, active drug use, full-blown addiction, non-fatal overdoses, and fatal overdoses. And really this is based on this kind of escalation of risk. As we understand social determinants and really the negative aspects of social determinants, so housing is not a social determinant, it is poor housing, that's the negative social determinant. But at every stage and phase of addiction, as an example, these social determinants play a role. And so part of our challenge in providing services is really to fully understand that. So one of the things as a resource, I've included a list of articles that really get at some of the issues. These, of course, are kind of focused on opioids, but you'll see them listed to the right. But when we talk about de-escalation of the risk, again, whether it's through harm reduction, treatment, recovery, and even prevention, again, social determinants operate at each one of these stages. And so as you are either developing, expanding, growing, figuring out, what's my role in this work, having a good handle on what those social determinants are critical to your success. I've often told folks if there's a mismatch between the strategy and the underlying problem, then you can deliver a beautiful strategy and have horrible outcomes, right? Because what you were focused on was not driving those issues in your particular community. So what does that mean? We just can't select evidence-based strategies and say, hey, I have an evidence-based strategy, or I have a promising strategy. Instead, you have to spend the time to understand what are those social determinants, because I think in many ways, they are akin to, as we talk about risk factors. what social determinants are operating in your communities, and how do they impact what you are attempting to change. So one of the things I want us to do is to really reimagine what that might look like in practice. And so, as I mentioned before, on the left side here are three things: social and community context, neighborhood environment, and economic stability. I want to reimagine them in the context of ACEs. And so I'm going to spend a few minutes talking about what that looks like. And again, for those of you in healthcare and those of you in education, I have not abandoned you. I promise we haven't. But in many ways, these are the things that happen to people more directly. And these on the other two on the right are some of the systems we want to begin to make sure we're dismantling as well. So what does that look like? I'm going to spend probably the next 5 or so minutes really kind of unpacking this slide. Not my slide. It comes from the CDC, the Centers for Disease Control, but I absolutely love it. And it talks about the pair of ACEs. And so when we normally think about ACEs, it's childhood adverse experiences. Here we divide them into two spaces: adverse childhood environments and adverse community environments. And so what's above that we normally see falls into the adverse childhood environments, what is happening to an individual. And then adverse community environments are really the things that surround them. And so I love this particular illustration because it shows the importance of what's below the surface, and although we can't see it, how it profoundly impacts the neighborhoods and communities we work in. So we'll start above ground. And so understanding like things like maternal depression, or emotional and sexual abuse, substance use, not of the individual we're talking about serving, particularly in a prevention context, but of those individuals they live with, right? Domestic violence, homelessness, incarceration, mental illness, divorce, and physical and emotional health. This list is not exhaustive, but it really talks about how if an individual is homeless, if there are multiple incarcerations, mom and dad aren't there, if there is history of mental illness, how do those things impact child development? And so how do they increase the risk of young people? And then how do we intervene? It first starts by understanding how many of these things are happening. How many of these things exist in the daily living or social context of individuals that present in our agencies? Below the surface is the piece that we often do not necessarily think is a part of our work. And that's a hard thing to really wrestle with, because in many ways, as I said earlier, part of what you do is dictated by the funding you get. But those in community environments include issues of poverty, discrimination, community disruption, lack of opportunity, economic mobility, and social capital, poor, and someone just a minute ago talked about the changes in housing. So poor housing, quality, and affordability being major contributors, and violence, right? And so those are the things that often are perceived as being intractable, or those are things that, we're focused on the individual, but not the environment in which they live. So for example, if you are delivering an intervention in a community-based setting, you're focused on that individual. But remember, that individual has to go back to a peer context that can almost erode what you've done in that intervention setting. So when they leave your intervention and they go back home to an environment that may have those childhood factors I just talked about, or they go back to a community that is ripe with many things you see that in terms of what it looks like, the roots. And so thinking about how do we tackle each one of those issues and understanding how they might play a role in how we serve young people. That is often achieved through screening, and this is where healthcare and education come in. Through screening tools in primary care settings, through school counselors who pay attention to young people. And then this has been exacerbated, and this is a momentary detour. One of the things that we've seen, for example, is a decrease in reports of child abuse and neglect during the pandemic. But it's not real because a vast majority of those reports happened when individuals came to school. Well, as we know, as we work, children, students went to school from home, the school context and the role of school teachers and counselors was removed. And so that's an example of like understanding the roles of schools, and as an example, the roles of primary care, understanding what are those risk factors that put young people at risk, and then reporting them. So this is an example, as I said before. While we're focusing on those things to the left, healthcare systems and education systems play a big role in that interaction. So I want to stop now because I want to talk more about the presentation of this diagram, and then to the great extent we got a conversation, then we're going to take a 5-minute break. So again, Tasha, any questions, comments about this presentation as it relates to what I'm calling the peer races?
No, not so far. Other than my own, but no, sir, no other comments from anyone else before our break.
So Tracy knows this. So if we were in person,
yep,
I have a Southern background upbringing, and so I would be looking out in the audience and starting to look at folks and point to folks. This is about call and response. And when Tracy asked me to do this, as I told him, this needs to be useful to you. And since I can't see folks, can't read body language, it puts me in a disadvantage. So I do want to make sure that this is resonating, it makes sense or not, and I have tough skin. And so I do want to make sure that those of you who have taken the time to be here today, that this has some relevance and interest to the working space that you are in. So I'm going to give folks a few minutes to just kind of give me your thoughts on what this might mean or questions that you might have.
Yes, makes sense and is very helpful and important, very useful and makes sense. It's coming through the chat now. Folks are agreeing that it is making sense and it is useful information.
All right, cool. So
on the spot. Mm-hmm.
All right, and so what I want to do now before I go into part 3, which is understanding issues around wealth building policies and structures, I want to take a 5-minute break. So it's 3:50 my time, 2:50 your time. So we're going to take a 5-minute break, and then at 3:55, we're going to resume the conversation for the latter half of the workshop. Okay? And folks can continue to put things in the chat. I'll review them and figure out how to incorporate them in the last part of today's webinar. So thank you. We'll resume in about 30 seconds. And as folks are coming back, I want to respond to at least 2 questions that I think Ned asked about understanding relationship between what's below the surface and its impact on individuals and how one might measure that. So yes, to some degree and extent, depending on your access, and I'll talk about data in a little bit, this is where the importance of data comes in, particularly the smaller unit of analysis of the data, the better. And understanding, for example, looking at where poor housing exists in communities, and understanding that where an individual resides and comes from is critically important. Poverty rates, for example, can really be honed down to the block group level. Issues of discrimination become a lot harder to measure. A lot's been funded in that space these days, but we are just beginning to really figure out how to measure and codify that. But also looking at issues around mobility, economic mobility. Raj Chetty work is amazing, that really talks about the importance of place, and that living on living in one census tract that might be less than a half a mile from another changes life expectancy by 10, 15, 20 years. Amazing. But it speaks to the importance of place. And so understanding that and tapping into those data sources become really important. So I do think more has been done in terms of kind of codifying some of these measures. Like I said, discrimination is probably the ones that's more difficult. Also, someone asked about trauma. And so I think you're going to be very happy with what's to come. And we're going to talk about trauma. And I look forward to kind of hearing your thoughts about it. So let me continue. So the third part was about understanding differential access to wealth building policies and structures, how to create unconditioned and good health in communities across the United States. I'm only going to spend a few minutes here, but I want to share something that I think that's relevant to the state in which you live in. So all of you are familiar with Redline. And so this is Milwaukee, and these are communities in Milwaukee. And so this is illustrative of the places in the salmon, darker colors where you see where it says hazardous. They map directly onto the red line that happened in Milwaukee in the 30s, 40s, and 50s. And so it's an example of how policies put in place decades ago impact communities to this day. And so, as most of you know, all of you know that home ownership it was a way of wealth building. Well, with redlining, that opportunity for wealth building did not exist, and many of these communities in Milwaukee are still impacted by that redlining. And so that's an example of how not just income but wealth building policies or policies designed to stifle wealth building continue to have lasting impacts on communities. And so and so this is a wonderful, I shouldn't say wonderful sample, a clear example of how policies in the past still can have impacts on communities today. And so so understanding that is important, again, about community context. Is the redlining still going on? No. But you create these systems that are much easier to build than dismantle. And so figuring out strategies that really take that into consideration are key to kind of long-term economic health of communities moving forward. So again, I don't want to overspend time here. It was an interesting question posed. And so here's one example of that. And there are others. So, tax credits for communities in terms of investment. As a classic, if you look at in Los Angeles after 1992 riots and social unrest with Rodney King, all those investments and tax credits went away. And so no one's coming and building. Communities don't thrive. And so then there's issues of distances in terms of transportation policies, such that if you can't get to a job, and you can't keep or have a job, but you would have much easier time of having a high paying job if those jobs would move to these communities that often been decimated due to prior policy. So those are examples of where those policies get in place that impact the issues around poverty and unemployment, and then subsequently that health and behavioral health. So what can we do? What should we do? How should we think about doing it? And so I want to spend as part 4 identifying examples of effective local, regional, national strategies for improving systems and policies that impact or affect social determinants of health. So I want to start with talking about where the greatest impact occurs. Each of you can find yourselves on this pyramid, whether that is in the counseling and education spot, clinical interventions, long-lasting protective interventions, changing the context to make individual default decisions healthy, and social economic factors. Those things in that social economic factor at the bottom of the pyramid have the greatest impact on improving health. And it's probably the place that we are least equipped or often least worked in. Most of us are in those other 4, and so and each one of them is equally important. But understanding impact is important. And so how do we get there? This is where the importance of partnerships come in place. And so where you may be focused on counseling, education services, understanding who's working in the other spots and how you might work together. And so, and increasing the impact. So I love this diagram. And it is not a matter of saying, hey, if I'm at the top of that pyramid, I'm having a less impact. Your impact is important, but it only explains a small portion of what I call a variance in terms of changing outcomes. But it's a needed and necessary piece. So don't hear anything I say that would suggest that this is not important, but it's also understanding what the contribution to change is. And so often we implement strategies and they're important, but they don't move the needle as much as we want. That is in part because it takes all of these pieces to really make that happen. So here's what I like to offer. This buckets of prevention framework. And so it talks about the importance of how each one of these pieces are equally important. So the traditional clinical prevention that, evidence-based services that happen in settings to innovative clinical prevention where you really are moving moving services outside of clinical settings, right? And that's understanding where people are and bringing it to them as opposed to them coming to you. That gets us to a public health approach. It really talks about whole total populations and community-wide prevention strategies. And what that really requires is folks working in tandem, understanding how your piece of the work that you do fits into a larger puzzle. And so there's a way in terms of reducing inefficiencies, reducing duplication of efforts, a clear understanding of how those pieces work together. And so that's one of the things that as you are continuing to do your work, planning out your work, by first understanding what do our social determinants look like, who's actually trying to address those social determinants, and how might we partner to understand the collective value of our work as opposed to the individual solo part of our work. So I want to provide one example of what that might look like in terms of some work that I have been privileged to be a partner of, but it's work that was developed out of the Prevention Institute out of California. And it's really around this notion of adverse community experiences and resilience. And the most important thing here is resilience. And as I take you through the next couple of slides, it's really about how this focus on resilience, it can be a response to those two ACEs I mentioned earlier. But this all first starts with understanding the role of trauma and the role of trauma in communities. And so the kind of origins of this framework really were focused on looking at what communities were experiencing and almost stumbling into the role of trauma. And trauma can manifest at a community level, not only as the aggregate of individuals. So it's not saying, hey, if you have lots of individuals within a community who have trauma, then the community has trauma. But instead, a neighborhood who has experienced trauma. And that becomes not at the individual level, but really thinking about that neighborhood as a unit in and of itself. Community trauma is the impact of what we call chronic adversity, and that can be issues like violence, structural violence across a community such that it is so ubiquitous that it becomes a part of the norm. Trauma is a barrier to finding effective solutions because to promoting health and safety and well-being because it erodes trust. And so, and we don't necessarily focus on it because we don't see it in the way we see other issues. And then the manifestation or symptoms of community trauma are present in both social, cultural, physical, built, and even economic environments. And so, and when the Prevention Institute was working with communities around some of the social problems, this issue of trauma kept coming up over and over again. So they really spent their time kind of developing a framework to better understand that. And out of that, they talk about the following. What are the symptoms of community trauma? And so this particular slide really kind of puts things in context. On the left-hand side, you see these important things about people, place, and equitable opportunities. And so people really, that's the social cultural environment. Again, we talk about social determinants of health, where people live, play, and learn, and understanding how things impact them. That place, though, that's that other part of it in terms of physical and built environment and how that impacts outcomes. And then none of that really can change if we don't have an increased and focused set of strategies that really think about equitable opportunity, and that's educational and environment. So what does that look like? So when we talk about equitable opportunities, that can be intergenerational poverty, long-term employment, relocation of business and jobs, limited employment, and disinvestment as communities change and shut down, particularly those of you who are in rural communities who have lost, employment to manufacturing employments, how that can decimate a community and what's left in place, and understanding what those disinvestments do to individuals. And then it gets the issue around social isolation, I'll talk about in a minute, understanding that and the importance of renewed or focused on new equitable opportunities to address those things. When we talk about place, and this is deteriorated environments, which are unhealthy and often dangerous public places with crumbling built environments and unhealthy products. What's unhealthy products? This is places, and we talk about food insecurity, where there are grocery deserts and everything are convenience stores who sell nothing but bad stuff. And so folks do not have easy access to healthy foods, as an example. So those are unhealthy products, but those aren't only unhealthy products. Easy access to firearms, those are also unhealthy products. So understanding place is critical here, and as symptoms of community trauma. And then last is people. Disconnected / damaged social relations and social networks are critically important to changing, to really improving the overall health of communities. The elevation of destructive, disciplining social norms, but also a low sense of collective political and social efficacy. And that's around having the ability to believe that you can change your circumstances. And to the degree and extent those things don't occur, all of them exacerbate this notion of community trauma. But you came to hear solutions. And so, and just kind of describing the problem is only step one. And so you'll see in this diagram, what would that look like in terms of potential strategies? And I mentioned earlier about the importance of looking at, this gets at the issue I think Nate asked, what's at the individual level and what's at that community level root. So I'll start right to left here. As we talk about individual approaches, things like trauma-informed care, mental health services, those are things that really focus on reducing the individual impact of community trauma, but also in terms of reducing those risks and focused on improving and or changing those social determinants of health. The community strategies around people, place, and economic opportunities could look like the following. So restorative justice practices, healing circles, economic empowerment, workforce development, and investment in resources would be examples of strategies that really impact equitable opportunities. Place includes things like creating safer public spaces, improving the built environment, investing in parks, housing, and transportation. And the people part is about rebuilding relationships and networks, strengthening healthy social norms, and promoting community connection. All of these types of activities are currently happening in Milwaukee as a part of what they call Blueprints for Peace, that came out of work directly focused on community violence. But again, this framework can be used for all community issues, to kind of understanding the role of trauma and whether that's substance use, violence, or other related outcomes. So that's the first part of it. And then the second part of it is the importance of systems. And so as we think about the work we're doing, it in many ways comes down to healing. And that's healing among people, healing within places, and healing with equitable opportunities. But all of that is surrounded by systems, and they happen across systems. And so to the extent that we can begin to understand the role of systems and systems change, That's how we begin to change outcomes in communities over a lasting period of time. So whether that's thinking about systems from an economic piece, justice, housing, community development design, immigration, and education, all of those things have to be thought about in concert. And so the only way you do that, of course, is about building partnerships, understanding how those systems operate. And as many of you are individual organizations providing services, and in many ways, in your own respective systems, but understanding how your work and the systems that you do your work in, how they should be interacting with the surrounding systems. I use the word silos and being disconnected probably too loosely, but none of what we do happens in isolation. None of what we do is not interrelated or interconnected. Again, we are forced to operate in that way because of the way in which resources are provided. But it's my contention, and this is just my opinion, so take it for what it's worth. Until we understand the value and importance of connections within those systems, we don't change outcomes in the way we want to. So that gets back to this pyramid again around understanding how you link and connect across these different sectors with respect to your outcomes. So for those of you who are, for example, part of coalitions are about bringing folks to different sectors. So you may not even be providing direct services, but it's about bringing different sectors together to look at problems in a more holistic way. And now through the lens of understanding social determinants. That is one example of what that might look like. And so what I ask and encourage you all to do as you leave this training and think about your work, who are your partners and where do you need to kind of think about engaging those partners? Because when you do that, again, getting back to my other slide here, is really about what does that total population of community-wide prevention look like? It is predicated on overlapping interaction and some folks use the term of collective impact, meaning that there's shared vision, shared values, shared resources, shared approaches to how you think about the delivery of services. No, it's not easy. But what I would say is we can continue to do the same thing and expect different results. And I think that's a definition of insanity. And so how do we begin to understand the importance of partnerships to really moving that work? And so the work in Milwaukee has been, and working specifically with the Office of Violence Prevention, has been amazing in terms of the number of sectors brought together, creating a written blueprint around what needs to be done to address violence, but in coming with that, the violence, also child abuse and neglect, and all the things that drive that are many of the social determinants we've talked about. So that's one example, and I'm more than happy to provide Tracy and the folks at Wisconsin with some other examples to consider as you move forward. But all of that, again, is predicated on more effective partnerships and understanding what's driving the particular issues in your locality. So before I move on to part 5, I'll stop now and see if there are questions really about the importance of how all these pieces might fit together as you think about the work you're doing. So Tasha, what do we have in the chat?
Not much. You have several folks that are agreeing with you still. Rebecca believes in the collective impact there in Door County, and she has several examples regarding that. But other than that, you don't have many questions. Folks are just saying great examples that you're providing.
Okay, great. Sounds good. And so before I move, just want to make sure, any questions from anyone that they want to come off mute and ask?
Yes, Susan has a question. She may want to come off mute, but I'll read it because I just saw it. How does asset-based community development work with this? That is Susan's question. Okay.
So Susan, I think I know what this is, but I would much rather ask you first, describe for me what you mean by asset-based community development, and then I'll answer the question. I want to make sure I I have a definition in my head. I need to make sure that's how it what it looks like in Wisconsin.
So I am working with a small group in a rural community, and we're using asset-based community development to try to connect individuals, discover their gifts, connect them to each other, but it's a strengths-based approach. So it's looking for, how communities can come together to solve some of the things that they'd like to work on, see what they have that's going for them, but then also identify other things. Like we do have an issue with housing here, as far as finding rental properties for people that can't afford to buy homes. We also have an issue with childcare services, trying to find those available to people so they can go to work. So it is actually more of taking down those silos and trying to connect, people. And it almost sounds very similar to your blueprints for peace, which I'm going to check out after this is over with and see how that would work. So in creating a strong community, you're reducing the amount of, fear that people have. They've got somebody that they can rely on because people are more connected. Works well in small towns where we have limited resources and we can share resources and talents or skills to help each other out. I guess, that's kind of, it sounds similar to what you're doing.
Yes, no, wonderful description of what you're doing. Yeah, and I think yes, and so it would be applicable. It definitely will work, and part of that again is really understanding what those major issues are, and when bringing people together, we all come to the table with our perspective on what the issue is, what's causing the issue, and what you believe to need to be done. Emphasizing the importance of it being data driven, and particularly in the context of social determinants, then allows hopefully for a conversation around doing the things that give you the greatest opportunities for success. That's the first thing. The other piece I love, and I'm going to, some of my research focuses on social capital development. I'll touch on it a little bit today. It's a whole set of different body of work, but it's an importance of social connections. And we don't value social connections enough because they often, I believe, they can change communities' trajectories. And so those are things where there are different types of social capital, and it's all about not what you know, but who you know, and how, and that leading to access to resources and opportunities. So in thinking about the work from a collective impact perspective, adding a social capital framework, I think also moves the needle down the road. So, but I think it definitely will work. Sherry also asked about does wraparound services work when clients re-enter the home? Ooh, no easy question today. That is a tough question. And it's something that we often don't really deal with because, again, I talk about, you can work with a young person in a setting, but you send them back to the place that created the reason you're working with them. I don't have a good answer other than I think much of what we teach and the skills we give folks, it gets eroded when they go back to those same environments. And so, and for young people, that becomes really, really hard because, they have less efficacy in terms of, not going back to that community. So wraparound services are good. But in many ways, until we change the environments in which people live, it becomes a Band-Aid. And that's not, and I don't mean Band-Aids in a negative way. What I mean is that you get re-exposed, re-traumatized when you go back to those environments. And so what that means is if you can make that intervention whole family, so it's not just the young person as an example, but how do you incorporate at least a family unit in it? And I think that increases the chances for better and healthy outcomes. So I hope that answered. So this last question was one that I thought was completely above my pay grade, but for better or worse, I like a challenge and an opportunity to see if I can meet that goal. And so Tracy and Ms. Bernstein and others wanted me to talk about evaluating and applying Wisconsin's Governor's 59 order in terms of diversity and inclusion. And so, and more specifically, being intentional about dismantling individual and systemic racism, discrimination, and bias, as well as equity and inclusion. So I thought about that and I was like, yes, you need to do all those things, and no, it's not easy. And so one of the things I want to start with is that for those of you who are part of human service agencies, I want to talk about some of my social capital work. And so part of what we're trying to do is understand best practices around social capital integration and development in human service agencies to address issues like unemployment, poverty, and health and well-being. Out of that work, we did come up with a set of practices, but what predated some of that work, what came out first, was this notion of principles and principles that need to be adhered to in terms of doing work, doing this work in human service agencies. So I think, when I talk about this, it gets at some of the issues, particularly the second around equity and inclusion. So we, in our work, we came up with these 5 principles that really need to be adhered to and kind of doing the work in your organizations. And the first is about people at the center. And so we're really talking about participants, clients, patients, whatever term you use, are viewed as experts. And so this gets back to the importance of understanding the importance of lived experiences. And so through having participants kind of drive part of the process where they feel respected, creating trusting relationships really goes a long way from really looking at some of these issues of inclusion. The second principle is around thinking about relationships as assets. And so, and what we saw was programs that focus on social capital, but think about it as a critical asset based on the individuals that they have, were fundamentally more stable over time. And the second was staff and participants as partners. And this is about power dynamics, right? You come into a substance use agency, or you come into a reentry program and folks feel like, they've been looked down upon. And so how do you create environments where staff and participants are partners? And in doing that, you have to be very attentive to the power dynamics. When organizations do that, their outcomes are much better. The next is around cultural competence. And so that's really about recognizing and being aware that staff and participants come from very different backgrounds. And as a result of that, being open to cultural perspectives and working together, it's critically important. And that really gets at some of the issues in order around equity, diversity, and inclusion. Equity, diversity, and inclusion can show up in many ways, but all of that is really kind of subsumed under the importance of cultural competence, because that's about understanding who people are, how they show up, and being understanding of their perspectives and backgrounds. And when you do that, you should be engaging them in a very different way. And so, and sometimes that's based on race and ethnicity, but that's based on morality, that's based on social political background. And so it's complex, right? But if you don't understand that, then you don't engage folks, you don't build those relationships, and you don't keep them involved. And the last is around emotional intelligence. And that's really staff being able to navigate the emotion of those who they come in contact with. And emotional intelligence is really a term that's not often used and is new, but to the degree that you can understand. So for example, if you're working with LGBT communities and don't understand the issues around transgender issues and substance use, for example, there's an emotional intelligence that's key to being able to successfully deliver your interventions. And so, so I share those as principles to abide by, that to some degree and extent address some of the issues related to the governance work. Not all of them, but I think some of them. So in keeping with that, and I'm looking at time, that relates to also how do you leverage and develop. Thinking of social capital again is around building networks at multiple levels. So at the individual level, it's about developing trust, understanding the importance of relationships, creating organic space, and this is a youth context, so that your individuals you're working with can come together based on their lived experiences and learn from that, and you facilitate it. And then I said, and that's about also embracing social media platforms when dealing with young people. If we're thinking about it at the organizational level, this gets at that pyramid, developing partnerships that lead to bigger opportunities. And so if you can begin to simple things like developing MOUs focused on youth recruitment, and that you're all not serving the same young people. Either you are doing integrated collaborative work such that an individual might get part of the services here, or part of your services there, but the same individual is not getting the same services from the same organizations. That as an example. Then let's consider collective impact as a framework for collaboration. Again, it gets by developing these partnerships. Again, it will allow you to really increase your reach, and hopefully by definition also move those needles and the things you want to change. And then connect programs across organizations. And this is where social capital, where agency X does Y, and you develop a relationship. And so you don't have to be the jack of all trades. You do what you do well, and you can refer them to the other. So that's kind of developing organizational level social capital. And then the last piece is at the community level. And so how do we thrive despite despair? And so what we know is, and this is, churches used to serve and do still serve this purpose, right? How you create community connections so when people have economic downturn, which leads to despair, that often leads to issues of mental health and substance use. If there are community systems and both civic and community engagement that fill those gaps, then you can see where two communities that have the same economic challenges have very different outcomes with respect to substance use and mental health. That's because there are social networks put in place that allow folks to fall into the cracks. It also means you're addressing stigma with intentionality. Opioids is a great example, but all substances, particularly mental health. We think about mental health and stigma and communities of color, their reluctance to engage. How do you reduce stigma in a very intentional way? Also gets at issues of equity and the utilization of healthcare services, again, in response to Order 59. Also identifying and addressing those restrictive policies. Taking a step back, what do we do that we didn't even realize is actually restricting folks from getting access to our services? For example, some folks wouldn't pay for, didn't see the value of telehealth. COVID-19 required us to figure out different ways to deliver services, and people now see the value of telehealth, or even and how we provide naloxone, how we provide Narcan and other services that were changed in restricted policies, and understanding how we get past those to build service delivery, and then also developing community-wide resources and shared spaces. Again, that's a way of making sure we maximize our involvement, create more equity in terms of service delivery. But in a simple thing, this all comes down to trust. And so as we think about this work, how do we get back to building trust among the organizations who are designed to serve and working with the communities that we are trying to serve? And so that's really, how do you measure it? Someone will probably ask, it's complicated. But if you are intentional about building it, it's a main ingredient that really goes into creating better relationships, social networks that I think can actually help you better address your social determinants of health, because everyone understands his or her part and how you collectively can move the needle. So I know it's almost 4:30. I did tell Tracy and folks I'd stay over 15 additional minutes for any Q&A, but I want to also, you'll see in the slides you get, here are some select social capital resources. We put together a fairly robust set of tools for managers around emerging practices, webinars and briefs on measuring and evaluating social capital programs, a social capital logic model, podcasts on managing practices. So you'll see folks who are working in the reentry space, the trafficking space, in terms of how they incorporate the importance of building social connections, some case studies, some virtual trainings. And so you'll see the link, and I'll work with the Assistant Secretary for Planning and Evaluation. So that's a resource for you that you can tap into. So I said these 7 questions, right, around being upstream leaders. So here's some things to think about. How will I unite the right people? That's about surrounding the problem, using data to understand. Again, it's not to say I have a strategy I want to implement. How does it impact the social determinants that really lead to the challenges that you're trying to change within a behavioral health context? In terms of fighting systems change, how you change the system, that's fighting for system change. I talk about shaping the water. And so that's really understanding how have systems in the past had policies, well-intended, that really change into barriers. Where can I find a point of leverage? That's getting closer to the problem. And that's, again, understanding which social determinants are driving the outcomes that you are trying to change. Early warning systems are important. And so this is about what I call deploying sensors. And so that's going out and figuring out how do we see incremental change. And this and in the book Upstream, Dan Heath really talks about that. How will you know you're succeeding? We talk about having pre-game, what he calls pre-game measures. And that's about understanding where you are before you begin. And then avoiding harm. That's about the importance of feedback loops. If you are not willing to change your strategies, modify your strategies, then you probably shouldn't be doing them, because you only are committed to one way. You end up potentially causing more harm than good. And so that's a hard thing. And then the last one, really around who will pay for it. How you align the incentives and then stitch together pockets of value. That comes to collaboration. Also, you probably have a unique time for those working with your single state agencies, the resources around substance use and what's particularly because of COVID and opioids. You probably have more resources than have ever been available. Make sure you know who your SSA is. Make sure you are understanding the types of things that are interested in funding, and then how do you align that with understanding your social determinants. So with that being said, I want to thank you all today for indulging me. And like I said, this was a 90-minute webinar, but I had actually allotted 2 hours. So if there are those who want to stay on a little longer, ask questions, engage me, I'm here for another 15 to 30 minutes. So Tasha, Tracy, Ms. Bernstein, Raina, how do you guys want to handle the Q&A piece now?
Thank you, Phil. Thank you, Dr. Graham. We appreciate that, man. We appreciate it. We hope, and I'm sure everybody got something from it. It was very important, and everything's good. So thank you very much. I'd like to now turn it over to Tasha, and then we'll turn it over to Sister Bernstein and Raina as we close out, if there's not any other questions.
Okay, so turning it over to me just simply means that I'm asking individuals to check your email. In your email, you have already received the PowerPoint presentation and a link, if you did not grab the link in the chat, to complete the evaluation. You know, we all know that evaluation is really important. It helps us to do better and get better responses. And so if you could do that, I would really greatly appreciate that. And if there are any questions now, we can handle answering questions in the chat, or you can unmute yourself because Dr. Graham is still on, as he indicated, for the next 15 minutes or so to answer any questions that you have. But if you go ahead and grab that link for the evaluation, and you can check your email for the presentation, that would be great. Thank you. Thanks, Tracy.
And I see there's, okay, I'm sorry, Ms. Bernstein, go ahead. I see there's at least one question from Rebecca. So sorry, Ms. Jefferson.
No, I was just going to say there is one question in the chat.
Mm-hmm.
Great. So Rebecca says, we struggle with getting community members to participate when we offer opportunities to build individual and social capital. An example of this is Parents Cafe. We used to get good attendance pre-COVID, but now struggle to get couples sign up. Any ideas? We are geographically spread out county, so we've offered technology-based options like connecting over Zoom. Oh, what a great question. And I will, my first response is I'm quite surprised, because particularly in rural areas, we've actually found that Zoom increased participation because, again, folks didn't have to travel. But I wonder, and many of us experience this too, I think, again, Zoom fatigue is a real thing. And I wonder, this is a wonderful technology that allows us to continue to interact, given our the inability to be in person. But I also wonder how it impacts in terms of understanding the value of kind of in-person human interaction. And so I'm actually surprised for that. And so I do wonder if once we get back to a hybrid environment and bringing folks together, whether that will improve so that you're not solely based on a Zoom. I don't know what your resources are, and sometimes, incentivizing folks to attend through raffles and other incentives also can be a way to jumpstart that. And then the last thing I would say is, depending on the way in which these groups are assembled, having a champion and who promotes this work is the other thing to do. So, but that's without knowing how the program is set up. Those are some things that come to mind. But I will say, I'm actually surprised that Zoom didn't actually, given you in a rural community, didn't actually increase participation. So I know I didn't give you many ideas, that's some, so I don't know if you're still on or not, but I don't know if that's helpful or you want to provide some more context would be great.
I am here. Hi, I'm Rebecca.
Hey,
so,
Rebecca.
we're actually following the 5 for Families. So in other words, the protective factors framework for building strong families. And so our topics are related to those, one of those protective factors at each of the cafes. I'm wondering if maybe we back off on giving it a specific topic and maybe allowing for some feedback from our community on what they want to talk about. Maybe that would help. Is something I've been thinking about.
Perfect, because I think sometimes meeting people where they are, right? And also, again, COVID has created all these new challenges, and we stumble on them sometimes because we don't ask. So I should be paying you because you came up with your own answer here. I think you're absolutely right. Taking a step back, and I mentioned before about creating these organic groups, and that's really about letting folks figure out where the commonality is and coming together, starting there, and you can still get to where you want to go in terms of those specific things you need to address. But I do think people only come to things that they think are addressing the issues they have. And so if they don't see it in what you're providing, they either wait or they move on to some place else where it looks like, oh, that's exactly what I wanted to talk about. So Rebecca, I would highly recommend that as a step back and reframing. The other part about in those 5 principles, thinking about your participants as partners. To your point, work with them as this is where the champion comes in, having them help you come up with what we need to focus on, and that will give some level of ownership, and then it can domino from there.
Thank you.
You're welcome. Other questions, either directly or in the chat?
Dr. Graham?
Yes.
My name is Mark Waka. I'm with Menominee County Human Services Department here in Kashina, the Menominee County, Menominee Indian Reservation. I really enjoyed your presentation. Just want to share some thoughts in regards to what we're doing back home here. I'm basically with the State Opioid Response Program, and I've been doing it for a couple of years. We were actually pretty instrumental through my program to develop what's called a Menominee Community Opioid Use Disorders Response Project. And what it entailed is the Menominee County and Menominee Tribe, the 2 separate governing bodies, coming together and collaborating with the services that we have. I actually went and did presentations to both governing bodies in regards to a building that we developed in one of our communities. And it's going to be used to collaborate with the service providers to do what we can to bring together the programs to help do some exact same things that you're talking about with prevention and so forth here. So it was really interesting for me, and I caught that little piece that you shared with regard to the buckets of prevention, and this kind of fits what we're trying to do, and the one piece that you mentioned in there talks about providing services outside the clinical setting. So our Circle House, which is deemed a collaborative intervention response community-led experience house in our community. So it's, taking resources and making them available to the communities. I'm a huge proponent of, not having people come to us, but we go to them in our communities and try and work what we can do to do the exact thing that you talked about in our communities. We're basically, well off in regards to, the traditions and cultures that we have. And, we've got a lot of issues with the meth and heroin and so forth here. But one thing that we really have we're really proud of is our traditions and our cultures that, we're wanting to use those to be able to, use those things to be able to help our people in our communities. We've got immersion programs in our schools, and we've got our young kids that are learning our language, and so forth. So it's really great. There's a lot of good things going on here, and I just wanted to share that with you, is because it's important for us to be able to tie into our communities and do what we can to try and, pull them back together and get what we need to have our healthy communities. So I want to share that with you.
No, thank you. And I would encourage all of you in these respective spaces to share with one another. As you build trust, I'd also encourage you to share successes and failures. We often only focus on the successes, but there's so much to be learned from our failures. And so, and sometimes you keep folks from making the same mistakes. And so, Mark, thank you for sharing. So there's a statewide mechanism to kind of showcase success stories, but also when I talk about creating learning communities around this work. And so, and that would require learning about successes and failures in terms of kind of improving the work that we do. But again, both equally important. So, but thank you for sharing.
Sure. Appreciate your help with everything.
Thank you. Other questions or comments? I'm looking at the chat as well. Yes, Mary, you're absolutely right. So yeah, kind of borrowing from other places in discipline and really thinking about, the pyramid is, and even that pyramid was new to me, and really thinking about what impact looks like, and then figuring out where you are and being comfortable where you are, but understanding this is where that's your contribution to better outcomes, and really attaching that to others who are working in adjacent spaces. Okay. I think time is a precious, precious commodity. I'd love to continue to talk to folks, but if I've answered all your questions, I'm more than happy to give folks back the gift of time, because the work you do is so important. So again, I want to thank Tracy Johnson and also the folks from the Wisconsin Connect for allowing me to share with you today. And again, as I said, this was intended to be a high-level overview, and recognizing that we could have done a deeper dive excuse me, in several of those sections. So I do appreciate the opportunity. I want to applaud each of you for the work that you do and continue to do as we tackle behavioral health and substance use, as well as mental health. We have a long ways to go, but I do believe understanding social determinants, understanding the role of partnerships and social networks will begin to get us to where we need. So with that being said, it's been a pleasure and honor to share with you today. And I look forward to future opportunities. So Tracy, I don't know Tasha, what next steps are, but I'll turn it back over to you guys.
Thanks a lot, Dr. Graham. We appreciate it. And we thank everybody for being a part of this, and look forward to more other opportunities. Thank you, Raina, and thank you, Sister Bernstein. You all have an awesome day and happy holidays.